Dr. Deyasagar, how are you?
Yeah, fine. I'm doing well. How are you, sir?
Good. Hello, Dr. Balachandran.
Hello, hello, sir. Can you hear, sir?
Very well.
Good evening. Good evening, sir.
Hi, Ajay.
Hello, good evening, sir. Good evening.
Good evening. Good evening. There's another educational program going on here in Bangalore.
In Kerala, there is another structural heart meeting going on as well.
I see. That is in Bombay.
This is Cochin.
There are far too many conferences now.
True.
Courtesy COVID. COVID has taught us a lot of things, including this.
COVID has taught us a lot.
Yeah, taught us quite a lot.
Good evening, colleagues. Welcome to another issue of Heart Failure Masterclass. This has been going on for a few years now, and all of us have learned a lot from master teachers and from our students. In these sessions, the aim is basically to teach clinical skills, also to upgrade our knowledge, but mostly how to interpret history, physical science, look at hemodynamics, and how to interpret those hemodynamics, all of which are very useful in taking care of our patients. So, with that little brief opening remark, Hari, over to you.
Yes, sir. Hello, can you hear me?
Yes.
Very well, sir.
Yeah. Again, one more episode of Heart Failure Masterclass. This time we have a presentation on heart failure in women by Dr. Veena. Then we have the case presentations. So over to Arun for the details, and then we will start the program. Over to Arun.
Thank you, sir. So, without today we have got three sessions basically. We'll have the talk by Dr. Veena Nanjappa, and then we'll go to the case presentation, and then we'll have the OSCE by Dr. Harshit. So, I request everyone to please be there for the entire program. This is going to be exciting. And the case presentation will also be a brief, short case. So, we'll try to wrap it up also on time. And then to start up today's sessions, I call upon Dr. Veena Nanjappa, who is the Associate Professor of Cardiology at Sri Jayadeva Institute of Cardiovascular Sciences and Research, Mysore, for her talk on heart failure, are women different? Over to Dr. Veena.
Thank you, sir. Very good evening to all my senior professors and friends. Coming to heart failure in women, it needs to be a busted myth regarding the fact that it is not same as what it is in men. So the disease burden of heart failure in women, as per the NHFR registry, which included about 10,851 patients, 31% of them were women. And ICC NHFR registry had 33% as women. So we can see that women are underrepresented both in Indian as well as global research cohorts. So the predominant heart failure phenotype in women is heart failure with preserved ejection fraction, whereas of that in men is heart failure with reduced ejection fraction, basically because ischemia is the driving force in causing heart failure in men. The traditional risk factors are almost prevalent both in men and women, but women are more susceptible to cardiac injury due to alcohol, toxin-mediated, tachycardia cardiomyopathy, and few other etiologies are specific to women like peripartum cardiomyopathy, chemotherapy-related cardiomyopathy, hypertensive disorders of pregnancy, collagen vascular disorders, especially the lupus, and Takotsubo. The cluster of heart failure with preserved ejection fraction also encompasses the ones which result in metabolic syndrome, the hypertension, obesity, and the diabetic trio. Atrial fibrillation is common in women cohort, and chronic inflammatory diseases like rheumatoid arthritis and lupus. Whereas in men, the predominant factors are CAD, MI, DCM, and alcohol related. So what about the prognosis of women and heart failure? As per the NHFR registry, the in-hospital mortality, the 90-day mortality and 1-year mortality between men and women are almost the same. Whereas in Trivandrum registry, the 3-year mortality in total is about 44.8%, and that of heart failure with preserved ejection fraction is about 40.8%. So when you look at this, with the fact that in women, the HFpEF is more common, so in fact, they tend to fare a little better with respect to mortality. And what is the care gap? So the mean age of presentation of heart failure cohort in women is about 60 years. And when you look at the GDMT in ICC and HFR registry, the ones women receiving GDMT was about 15.9% versus that of men about 18.8%. So there's a 3% gap of women and men receiving GDMT. And women are less likely to receive beta blockers and RAS inhibitors. That may also possibly due to the fact that HFpEF has very little mortality benefit, reducing medications apart from RAS inhibitors and SGLT2 inhibitors. Coming to the anatomical and physiological differences, women tend to have lower LV mass, smaller LV cavity size, smaller coronaries, and slower rate of myocyte apoptosis. However, with increasing age and postmenopausal state, the LV mass tends to be better preserved in women. And they've also demonstrated a greater predisposition for endothelial inflammation and coronary microvascular dysfunction. And they have a higher predisposition to age-associated ventricular arterial uncoupling. So what it means is the ventricles and the arteries tend to work in tandem together. And you expect the elastance should be half of ventricular elastance. If this doesn't happen, then there is increased peripheral vascular resistance. Again, becomes a reason for blunting exercise coupling reserve. And coronary syndromes that are common in women, and specifically in women, is the MINOCA, which is about 60% cases of MINOCA are because of present in women, diffuse non-obstructive CAD, and microvascular dysfunction. And there are also sex differences in the immune response. There is upregulation of pro-inflammatory genes in women, activation of inflammatory T cells, and generally heightened inflammation milieu in women. And imaging studies have shown that women comparatively have concentric LVH, whereas men tend to have eccentric LV remodeling, more severe diastolic dysfunction, higher diastolic stiffness, higher pulmonary capillary wedge pressure, greater LV end diastolic and diastolic elastance, and higher LV filling pressures. So this is basically driven by the risk factors, that is hypertension, obesity, which is common in women, whereas it is MI and ACS situation, which causes the eccentric remodeling in men. And when you look at the subcellular level, there is extracellular matrix expansion in women, whereas there is higher rate of necrosis and apoptosis in men. So coming to hormones, with regard to hormones, it remains not really well understood why estrogen may be relatively protective in the development of various diseases. And however, when we do the hormone replacement therapy with estrogen, it actually increases the disease risk state. Whereas high testosterone levels lowers the natriuretic peptides and predisposes to the natriuretic peptide deficiency physiological state, what is seen in postmenopausal states. So comparing premenopausal women with heart failure with postmenopausal women with heart failure, the vascular function is preserved and in premenopausal women, and it is impaired in postmenopausal women. There is higher rate of fibrosis, inflammation, and HFpEF in postmenopausal women. And estrogen is an important hormone, basically because it has protective effect from developing diastolic dysfunction. It modulates the RAS suppression. It reduces the angiotensin and aldosterone levels. It also reduces the LV hypertrophy and remodeling and fibrosis. So basically, at the end of it, the estrogen maintains lower vascular resistance, prevents the afterload increase, and delays the progression of heart failure. Inflammatory milieu tend to be higher in women, with the diffuse fibrosis is what is noted, whereas men tend to have ischemic focal fibrosis on cardiac MRI imaging. So the sex-specific risk factors, which are common in both the genders, but what is to be noted is women with diabetes have a greater signs of adverse LV remodeling, increased LV thickness and LV mass index. And though the prevalence of hypertension is both in men and women about 50 to 60%, women tend to develop threefold higher risk of heart failure compared to that of men. And though tobacco and smoking use is not to that extent seen in women, but if it is associated, there's a high, almost doubles the risk of developing heart failure. Socioeconomic status and disparities and financial constraints make them seek healthcare at a later aspect in the curve of disease. And that's why they end up presenting with severe disease. And what is common to child-bearing states is gestational hypertension, gestational diabetes, PIH, preeclampsia, and peripartum cardiomyopathy. And this is about 0.1 to 0.2% case of incidence, and it is usually seen because of advancing maternal age, increase in multiparity, PIH, and early recognition. Some numbers which we have to note with respect to PPCM is as per the ESC registry data, the 1 year mortality of PPCM is about 8.4%. What it means is 1 in 12 women die within 1 year of the diagnosis of PPCM. There is, however, high regional variation, which is more common in blacks. And when you look at the global registry, the mean EFA diagnosis is about 30%. And 2/3 of them have LVEF of less than 35%. 50 to 60% recover LV function within a year. Frailty in women and heart failure is another common condition. Frailty causes inflammation, sarcopenia, neurohormonal imbalance, and micronutrient deficiency. When they looked at global congestive heart failure registry, just the presence of frailty gave an additional prognostic information, and presence of frailty ended up making women fare worse in their outcomes. And when we look at this major trials of Paradigm HF, Atmosphere, and DAPA HF trials in patients with reduced ejection fraction, almost 2/3 of these participants were identified to have frailty. And another meta-analysis of heart failure cohorts showed that women have 26% higher risk of frailty than men. Coming to cancer and chemotherapy, with breast cancer being the most common cancer in women and women living longer with this disease, studies in breast cancer survivors also have shown that CV mortality exceeds that of cancer mortality. And two noted culprits with respect to cardiomyopathy causing medications include the doxorubicin, which occurs in about 10% of patients receiving them in standard doses, and trastuzumab has cardiotoxic effects in about 13% of patients who receive this drug. Radiation therapy has also been implicated in developing valvular cardiomyopathy, ischemic cardiomyopathy, as well as diastolic dysfunction. And women tend to have higher prevalence of lupus, rheumatoid arthritis, and mixed connective tissue disorders. Coming to sex differences in heart failure therapies, what has to be noted is women have shown to have up to 2.5 times higher plasma concentration of some of the heart failure medications, like ACE inhibitors and ARBs and beta blockers. This could be because of their inherent metabolism, both hepatic and renal. And so there is no particular study to address this issue, whether women require lesser doses compared to that of men to achieve the same targets. But the GDMT guidelines is equal to both, is irrespective of the gender. Such higher plasma concentration can impact the dose response and often leads to exacerbated side effect profile in women. In HFpEF, there was a discriminatory response to spironolactone as well, as seen in TOPCAT trial. TOPCAT trial is the only heart failure related trial which had 50% enrolling of women as participants. The risk of side effects is often underestimated for women based on results from trials of heart failure drugs, in which men are more likely than women to be enrolled. In case of Paragon HF trial, where ARNI was used in HFpEF, the likelihood of reducing hospitalizations and death, women fared better than that of men. And when it comes to device therapies for heart failure, women are less likely to receive an ICD than men. And some large meta-analysis of ICD trials have shown no benefit in women and fewer appropriate ATP therapies and ICD shocks in women. And usually men receive it for, the reason for ICD indication is usually ischemic. So there is a higher milieu of developing arrhythmias, whereas women tend to get their ICDs usually for the indication being non-ischemic cardiomyopathies. And women are found to be better responders for cardiac resynchronization therapy. And many times it is heartening to see that they also happen to be super responders in about 30% of cases. And women can often have mitral regurgitation secondary to LV remodeling in heart failure with reduced ejection fraction, similar to that of men. But they are referred for mitral therapies, be it TR or MV repair, or usually when they're referred, usually it is at end stage and they end up having a valve replacement rather than repairs. And when we look at advanced heart failure therapies, only 26% of referrals for transplant were of women. And a lot of times they died in the waiting list, waiting for transplant. LVBB pacing for LV dysfunction women both have comparable outcomes, both men and women. And cardiac resynchronization therapy in women, women show greater LV ejection fraction improvement and better LV remodeling. And women respond best when they have a true LVBB morphology, non-ischemic cardiomyopathy, moderately prolonged QRS, even shorter QRS of 130 milliseconds, they tend to fare better with CRT rather than the conventional indication of 150. And when we look at TEER therapy, despite similar mitral regurgitation burden, women tend to have severe symptoms, higher rates of AF, and lower utilization of interventions. Though TEER shows comparable short-term success in women, but because of delayed referral and comorbidities, long-term benefit may be limited. And women tend to have more of atrial functional MR compared to that of primary MRs. And coming to tower, where the manifestation could be ADHF, women undergoing tower are typically older at presentation, more likely to have frailty, greater hypertension, greater CAD, and they present at a more severe symptomatic aortic stenosis stage with greater LV dysfunction. Looking at the therapy per se, there are some anatomical variables like they tend to have smaller annulus, lesser vascular access options, elliptical annular shape, less calcification burden, greater fibrosis, and low coronaries. And when we look at coming quick to the closure, from the Momentum 3 study, there was no difference in the primary composite endpoint of survival when LVAD was used for both men and women. And women account for only about 25% of heart transplant patients in US, and they tend to have higher mortality in the waiting list. And women who do receive a heart transplant, they tend to fare almost equivocal in the long terms. But acute rejections are a little more common in women because of pregnancy and because of alloantigen sensitization that happens during pregnancy. So survival dynamics with respect to heart failure, men decline faster, higher early mortality. But however, the curves converge between men and women with a 50% survival at 5 years. So the challenges with respect to women and heart failure is older age, higher comorbidity burden, greater HFpEF, delayed diagnosis, underrepresentation, lower access to specialist centers, advanced heart failure care, health system issues, cost barriers, poor follow-up, and limited guideline adherence across India. And way forward is probably increasing their enrollment, doing women-specific studies, understanding their pathophysiological differences, focusing on optimization of sex-specific risk factor, ensuring equitable health care access and advanced therapies. Thank you.
Thank you, Dr. Veena. It was an excellent talk. Chopra sir, comments?
Excellent talk, Dr. Veena. I would like to have a copy of this.
Thank you so much.
Two things came out very clearly. I think it's not that women have less heart failure. It is because of social reasons that they get enrolled less often. They receive less treatment. They receive treatment rather late.
Yes.
It also came out in Paradise Heart Failure trial that although the trial was negative, but women seem to benefit more with ARNI after acute myocardial infarction rather than men. The third thing, as you have already highlighted, is that the response to cardiac resynchronization therapy in dilated cardiomyopathy is much better in women than in men. But what came as a surprise to me, which I didn't know, was that women have two and a half times higher level of ACE, ARB, and beta blockers. Is that well established, or there are only some publications? I
It's
didn't.
not well
I didn't know
established.
about this.
They
No,
tend
Yes, Hari.
it is said that 100 milligram of metoprolol in men is equivalent to 50 milligram of metoprolol in women. It is half dose will have the same effect. Metoprolol. Metoprolol has some studies.
But she also mentioned ACE and ARB also. Is that basically of lower weight, same weight? What?
Yeah, Veena.
Veena?
No, there's not large data, sir. There are some studies which suggest, because they say it's basically related to the metabolism and low body surface area.
Yeah, but if the body surface area is the same, for example, if it's a large woman and a large man with equivalent weight, would the response be different? And why is the metabolism different in women? Is it something to do with hormone or something else?
Lipophilicity and hydrophilicity also matters. Lipophilic drugs are more potent in women, and hydrophilic are more potent in men. So that difference is also there.
Is there any data to say that visceral obesity is more in women?
Visceral
Yeah,
obesity is conventionally more in women,
women,
but
especially in
to
Indian women, they have more
even
visceral obesity than men.
it's common both in men and women. Even if they're lean as well, visceral obesity is more common in Indian population.
Thin fat Indian. Excellent.
I
Thank you
would,
so much.
And
no,
very nice talk, Veena. Very nice. All the data you have compiled.
Thank you,
there's
sir.
only
Thank you
one
so
point
much.
I would like to ask you. How much have you seen stress cardiomyopathy in women? Uh, uh, is it common, not common?
It is common, sir. But to establish stress cardiomyopathy conclusively, we will have to do the angiogram and an LV angiogram.
That is true.
Otherwise, we have
But
to chronologically, clinically follow them up for
yeah, though
echo
supposing
findings.
the patient presents with stress cardiomyopathy, everything is reversible, or they have a residual and go on to develop heart failure.
Some of them, I think about 5% of them can have a malignant form where we can even lose a
Correct.
patient. It need not necessarily, there's not always full improvement.
I think to answer the question about drugs, I think when we use in women, elderly women, we do reduce the dosage of drugs, especially, and nowadays even DAPA, we are giving half the doses. So that is, uh, I mean, we don't know about studies, but it is true that they benefit with a little lower dose than men. The other question is about the mitral valve prolapse. How far have you seen mitral valve prolapse being followed up and going into heart failure, mitral regurgitation, and progressive? Because this is something which I think is more exclusively in women than in men, although other things like Marfan, etc., will have in men also.
Uh, so usually when we follow the cases of MVP with MR, we tend to send them for surgery early on. But
Correct.
what we often see, which is in those class 2B indication for tear therapy, is this atrial functional MR, which is often seen with
More.
RCM-like physiology, where you have atrial MR and and with secondary PH and with high LV filling pressures. These are the candidates who fare poorly with both the GDMT and they don't fall into the criteria also for interventional edge-to-edge repair therapies as well. And this subset usually develops in elderly age. And so these are the
Correct.
ones whom we don't have much answers to with respect to
And the
medications. But
last point is about
MVP with
chronic.
MR, we tend to send them for repair and surgery a little
Separately.
early.
No, the other last point, which I think is also important, is to identify and pick up patients who have chronic pulmonary thromboembolism, and then go on to develop RV involvement, and then subsequently, because that is when we pick up, it is common, but otherwise it's not that common. We used to think.
CTAP, the only problem with CTAP in our country diagnosis would be having them put through right heart catheterization, which
Yeah,
we don't
don't
often
use
subject
much.
most of the patients to. And that is the way of diagnosing CTAP. We invariably put them on medications. But I think we should look at sending them for surgery if it is located within the central and segmental 1 level of involvement of pulmonary organized thrombus.
Excellent talk. Anyway,
This mitral annular calcification with MR, in your observations, has it been more common with women or with men in the elderly and causing heart failure?
MAC is common in women, sir.
No, but as a cause for heart failure, how common is this MAC? Because of the elderly people now, more and more seems to be having MAC as the one of the causes of, and there is no
AF.
My findings
what do you call intervention that can correct that.
My findings will be anecdotal, sir. I can only speak for myself when I say it. That's probably seen higher in terms of women. Basically, because I think it's all related to the fact that HFpEF is more common in elderly women, and they are also the ones subset who develop MAC.
MAC, which produces mitral stenosis, now they use IVL, intravascular lithotripsy,
Lithotripsy, yeah.
they have been used. Some case reports are there.
Correct.
But
Triple M is having the data on it, sir.
Yeah.
By and large, it's a desperate attempt.
Yeah, it is a palliative only. It is palliative.
Yeah, palliative, and results are not that encouraging.
It's all palliative.
Yeah,
In an ideal situation, if MAC is 270/360, then TMVR can be considered, but it's an ideal situation. We can't offer it to all our patients. The expense of it.
Right.
Okay, thank you, Arun. We can proceed.
Yeah. Thank you, Dr. Veena, and
Thank
we
you,
had a
sir.
great discussion.
Thank you,
Wonderful
sir.
talk and great discussion.
Thank you.
So it's my privilege to call upon the examiners for the case discussion, Dr. Balachandra sir, Dr. Dayasagar Rao sir, Dr. Ajay Bell sir, and Dr. Harshit Kharif. For the case discussion, and I request Dr. Bibas from STPJ to be ready with the slides, and student panel, you can please turn your video on. The team from PJ Chandigarh, Dr. Chinmay, Dr. Mehari, and Dr. Karthik. Over to the examiners. You can share your slide, Dr. Bibas.
स्लाइड शो करना है स्लाइड शो करो पहले स्लाइड शो कर दो उसको हाँ अरे इस पे जाओ स्लाइड शो कर दो Sir, can I start?
Yes, please. But you haven't shared the
screen.
Your PowerPoint. What you do is you stop share and reshare again and select the appropriate application. Share and select the PowerPoint.
पहले उसको क्या स्क्रीन में विंडोज की होगी उसको ओपन नहीं होगी इसको एक सेक्शन कर देंगे अब उधर
Vinay, can you help?
Yes, sir.
Yeah, perfect.
Yes, sir.
You can start. Your slides are visible. Yeah.
Yes, sir. Good evening, respected teachers. Today we are presenting a case of Miss Diksha Singh, who is 29-year-old female from Barabanki, Uttar Pradesh. She works as homemaker, graduate, informant being the patient herself. She presented with the complaints of palpitation for last 5 years and breathlessness on exertion for last 2 years. On elaborating the history of chief complaints, patient was apparently asymptomatic on performing her daily routine activities until 5 years back, which she noticed palpitation, which were insidious in onset, regular, occurred during exertion, and was relieved on taking rest. And the patient described this as chest thumping. There is no associated prominence of neck veins or post-palpitation diuresis, or no abrupt onset or offset. She developed breathlessness on exertion for last 2 years, which was insidious in onset and progressive in nature. Initially, she felt breathlessness after walking for 2 kilometers or carrying a water bucket and climbing 2 flights of stairs, which was relieved on taking rest for a few minutes. That was suggestive of NOHA class 2. For the last 6 months, these symptoms got aggravated and feels breathlessness after waking for few steps, climbing 4 to 5 steps, even after taking bath. That is suggestive of NOHA class 3. However, there is no history of any cough, expectoration, wheeze, or fever. Since last 6 months, she wakes up from bed 1 to 2 hours after sleep due to breathlessness, which used to get relieved after walking for a few minutes. And she's also started feeling of shortness of breath just after lying down for the last 2 months, for which she had to sit upright for symptom resolution, and she used to sleep in upright posture by using a pillow. For these complaints, she consulted a local physician and advised some oral medications, which increased her urine output and symptoms got improved. Regarding negative history, there is no history of any nocturnal angina or effort angina, no history of any syncope, presyncope, no history of any bluish discoloration of skin and sclera or recurrent LRTI. There is no history of any hoarseness of voice, dysphagia, pedal edema, or hemoptysis. There is no history of any abdominal distension, jaundice, hematomesis, or melena. No history of TIA hemiparesis or abnormal body movement or focal neurological deficit. There is no history of any migratory joint pain, skin nodules. No history of drug abuse or previous cardiac surgery. Regarding family history, she is unmarried and lives in a joint family with her parents and a younger brother. There is no history of any cardiovascular diseases, no history of diabetes, hypertension, CVA, or rheumatic heart disease in the family. Regarding personal history, she has normal bowel habit, but the frequency and volume of micturition were increased since taking treatment. There is no history of addiction, and she is non-vegetarian, taking mixed diet. She lives in a Pakka house, having 3 living rooms and 1 kitchen hall. She belongs to lower socio-economic class as per the modified Kupusami classification. So my clinical summary is 29-year-old female presented with volume overload type of palpitation for 5 years and gradual onset dyspnea for the last 2 years, which has progressed over the past 6 months from NOHA class 2 to NOHA class 3 or 4, with history of PND and orthopnea, with no evidence of infective endocarditis or acute rheumatic fever.
So what is what are the possibilities you want to consider?
So, in my patient, as there is a short duration of dyspnea and there is rapid progression of symptoms, so I'll think for multivalvular heart diseases first. And in our population, the among the multivalvular heart diseases, rheumatic heart disease is most common. So,
So why
rheumatic.
do you think, see, the breathlessness is only from onset to class 4 is only 2 years. So do you
Yes,
want
sir.
to, how do you explain the breathlessness? Do you think it's mitral stenosis, a very rapid progression, or do you think it's something else?
Sir, as the patient presented with volume overload type of palpitations and having TVH feature, so regurgitant lesion will be more prominent.
So you think mitral regurgitation has caused the breathlessness from class 2 to class 4 over 2 years, mainly?
Sir, associated with other either MS or other regurgitant lesions can produce.
So you have
But the prevalence,
mitral
prevalence-wise,
stenosis with PND, no? PND means mitral stenosis is what we think. But can MR itself cause PND? If so, how?
Yes, sir. MR can cause PND, but in the late stage when there is LV dysfunction causing increased LVEDP and causing PVH, then it can produce symptoms like PND orthopnea. But prevalence wise, sir, mitral involvement is
Okay.
But primary problem was arrhythmia,
Palpitation, yeah.
yes, sir.
palpitation. So you think it is related to the volume overloaded ventricle and not a dysrhythmia?
Yes, sir.
Mhm.
How did you say that?
Because
difficult.
patient
Yeah, patient also had symptoms of left heart dysfunction. So basically, we need to have a disease that is rather progressed faster in the last 2 years. Generally, regurgitant lesions take longer time. They are tolerated better for longer time as compared to other lesions.
Stenosis.
So it is, unless a chronic regurgitation is complicated by a acute deterioration due to a structural abnormality or the onset of a dysrhythmia or some other complication that might have forced her to become more symptomatic with rapid progression. So you are only thinking of valvular diseases. Why not other forms of disease like cardiomyopathies?
cardiomyopathy patient can also present, but they usually present with PVH symptoms like dyspnea or LV dysfunction or orthopnea. But there is long history of palpitation for last 5 years. Volume, that is volume overload of load type of palpitation, sir.
So can you tell me some diseases where the primary abnormality of a cardiomyopathy is arrhythmia?
Tachycardia
No. Primary abnormality of cardiomyopathy
It's
is,
LVD.
is dysrhythmia. Young female.
Young female pericardium cardiomyopathy.
No, she is not married. She is not
Is
delivered.
unmarried. ARVD. ARVD.
ARVD. What is mitral annular disjunction? Have you heard of the term?
Yes, sir.
What is it? And how do they present?
There is actually separation between the this left atrial wall or mitral annular junction.
So how do they present?
There's arrhythmia.
Yeah, so the young female presenting with arrhythmia. That is also possibility. And she also has MVPS patients will have mitral regurgitation, right?
Yes.
So it is one of the things you need to think in a young female who presented with arrhythmia is this mitral annular disjunction presenting with arrhythmia. Any other cardiomyopathies presenting with arrhythmia as the primary presentation?
ARVD.
Sorry?
ARVD.
ARVD. So why not? So,
Because
but then
ARVD is not confined to the right ventricle, no?
Arrhythmia. But what is the presentation of arrhythmia? Do they present with just palpitation, or do they have anything else apart from arrhythmia?
Palpitation and exertional fatigue.
Mhm. What about a patient with Epstein's anomaly presenting with arrhythmias?
Epstein anomaly patients. Yes, sir. They can also present with arrhythmia, but gradually they progress to right heart symptom, right heart volume overload symptoms.
Okay. So you think, according to you, ARVD is primarily a disease of the RV with no involvement of LV. Do I understand you correctly?
Is it like that, or it is
LV
different?
can also involve.
We can also be involved.
Yes, sir.
So now they are telling it is
It's a
arrhythmogenic ventricular displacement.
ventricular, that's all. It can be
Yeah.
biventricular.
It can be right, although it is commonly right, it can involve both ventricles.
Yes.
So you need to think beyond just valvular heart disease. So young females, let us see, in the absence of this palpitation, what are the likely causes of heart failure? Young females. Just now we heard the talk about failure in women by Dr. Veena. She is unmarried.
Yes, sir.
So basically, what are the possible causes of heart failure in a young female?
So non-cardiac causes like anemia,
No.
thyrotoxicity.
We are talking about
cardiac.
she has got a cardiac problem. She went on to progress to develop symptomatic left heart disease by way of orthopnea and PNDs. So you cannot say it is just imagination. So it is real. So we need to think of diseases which can cause heart failure in a young female, apart from valvular heart disease, which is still the commonest. I do agree that valvular heart disease is one of the commonest things, in spite of all the talk about non-valvular heart disease. Anybody? What does the student panel think about it? This is from Chandigarh, right?
Yes, sir. Yes, sir. We are from Chandigarh.
Yeah. So, what do you think?
Mitral valve prolapse is one of the commonest causes. Other than
that we have
valvular heart
already
disease,
discussed.
other than
That's been discussed.
valvular heart disease, congenital heart disease like VSD and PDA can cause left-sided volume overload. So,
Oh God! At that age of volume overload, by the time, usually.
If there is a predominant restrictive perimembranous VSD, and if the AR progresses because of it.
Yeah, sure. So it is a VSD that went on to
Yes.
develop a complication like aortic regurgitation.
Aortic regurgitation.
And the cause of aortic regurgitation in those patients is due to?
Valvular cuspal prolapse.
RCC prolapse.
So it is cuspal prolapse. Cuspal prolapse is a feature of what type of VSD?
Perimembranous VSD.
Perimembranous, or is it more common with any other type of VSD?
Because there are two types, no? Van Praag has described two types which can occur. One is common in Asians, one is common in other.
Outlet VSDs primarily, sir.
Outlet VSD?
Outlet.
No. Can you just name the types of VSD you know of, other than subaortic?
Subaortic, subpulmonic, muscular.
No. Yeah, other than that, you just tell us the other types of VSDs. Just name them.
We usually say inlet, outlet, and muscular VSDs.
What about supracrystal?
Supracrystal, that is the one which has no AR.
That is the one, yeah. It's also important to recognize that VSDs can have cuspal problems of aortic valve that can also cause aortic regurgitation over a period of time, not necessarily always due to prolapse. Okay. Anything else? Any other diseases in a young female?
Young female with LV dysfunction, Takayasu arthritis is one of them.
Yeah, it can be.
Takayasu aortitis.
Yes.
Okay, that is one of the things. Mechanism? Mechanism of LV dysfunction.
Aortitis. One of the mechanisms is chronic aortopathy leading to AR, chronic AR leading to LV dysfunction.
You don't consider any other cause for LV dysfunction?
What about hypertrophic cardiomyopathy in women?
Yes, sir.
It may cause when there is MR, significant MR.
Significant MR in?
HOCM, sir.
HOCM. Yeah. HOCM, MR is a integral part of HOCM.
Atrial fibrillation is important part.
Okay.
At the age of 20 years, you get atrial fibrillation in HOCM. How common is that?
Among all the patients, 20 to 25%, 25 to 30% of the patients have.
This is your, but take into consideration people living beyond 50 years. Okay, the cause of AF in patients with HOCM, possible cause.
It is due to the chronic diastolic dysfunction because of the HCM leading to LA dilatation.
The substrate itself is arrhythmogenic.
No, that is non-obstructive. That is probably one of the reasons. We're talking about obstructive.
Okay.
How many types of MR can occur with hypertrophic obstructive cardiomyopathy?
It can be because of the leaflet involvement, leaflet displacement of the anterior and posterior mitral leaflets. That is one
What
of
do you
the
call
causes.
that? What do you call that? What is SAM?
It's a systolic anterior motion of the mitral leaflet.
Yeah, that is one of the causes.
Yes.
And that is proportional to
Severity.
severity of
LVOT obstruction.
Okay.
So there is also another cause for MR, which is not related to LVOT obstruction. So it is primarily abnormality of the mitral valve apparatus, independent of the LVOT obstruction. So how do you differentiate? And is it important to differentiate?
Yes, sir.
Can you differentiate clinically or by echo?
So clinically, all the etiologists will have a presentation like an MR. So it will be difficult to differentiate clinically. Echocardiographic involvement by echocardiography will be able to say whether there is a caudal involvement or there is a SAM. So
No. We are talking about whether the MR is due to secondary to LVOT obstruction, or is it a primary abnormality of the mitral valve apparatus?
We can say in clinical examination, sir.
How do you decide?
By doing dynamic auscultation.
So you do a dynamic auscultation, correct?
Yes.
Okay. So dynamic auscultation, what do we expect to MR? If the LVOT obstruction decreases?
The MR decreases. Yes.
So how do you decrease the LVOT obstruction at the bedside?
So we can either by doing a hand grip or by doing a
hand grip.
No.
How often have you done?
We can ask the patient to squat.
Okay. Fine. Anyway, let's go on to the etiology. Yeah. I think we'll move on to the physical science because we'll move on to the physical science.
Sir, physical examination part will be discussed by Dr. Panchal.
Evening, sir. Sir, I'll be presenting the examination part.
Yeah.
Patient was conscious, cooperative, well-oriented to time, place, and person. Height was 160 centimeters, weight 55 kgs, and BMI was 21.4 kg per meter square. Pallor icterus, clubbing, and cyanosis are absent. There is bilateral pedal edema is absent, and respiratory rate is 18 per minute, thoraco-abdominal. There are no peripheral signs of infective endocarditis. Pulse is 80 beats per minute, regular in rhythm, high volume pulse, forceful, brisk upstroke followed by downstroke. All peripheral pulses are palpable, no radioradial or radiofemoral delay, and condition of arterial wall is normal. Peripheral signs of AR are present, like Corrigan's pulse is present, Hill sign is present, and Dorosio's sign is also present. Blood pressure is 130 by 40 millimeters of mercury in right upper limb, 120 by 50 in left upper limb, 210 by 50 millimeters of mercury in right lower limb, and 210 by 50 millimeters of mercury in left lower limb. JVP was not raised with mean JVP of 7 centimeter water with normal waveform with normal respiratory variation, and there was positive hepatojugular reflux. This is the Landolfi sign.
Can you just clarify on the JVP? I mean, you never say water, no? I mean, you're actually physically seeing the JVP. So what do you mean by 7 centimeters? Is it 7 centimeters above the sternal angle? What do you mean by that?
sir, 2 centimeters above sternal angle, sir. 2 centimeters above sternal angle.
Okay.
No. What is the current recommendation of measurement of venous pressure? Current method, 2026.
What is the
accepted method?
Sir, we take while the patient is lying at 45 degrees, we take the
No. Can you?
vertical displacement.
I think that's not correct. If anybody can do anything better than that. Have you read the chapter in Brownwall at least? Physical science? Or let me ask the question the other way. Why is that method unreliable?
The sternal angle.
Sternal angle. Then you will understand why it has been deleted. Any idea? What is the assumption made in that sternal angle business? What is the assumption? Why do you choose a sternal angle as the reference point?
Because we consider our right atria, sternal angle of Louis is just above the right atria, and it is approximately.
Wait. That's not correct.
What is the phlebistostatic axis?
No. Actually, the whole thing was based on one premise, which has never been tested till about late 90s. It is assumed that the sternal angle bore a constant relationship to the midpoint of right atria. Yeah, which is supposed to be about 5 centimeters. That was only surmised. It was never tested. Then the trial came. Somebody using a CT scan in various positions have shown that this distance varies with position of the patient. That the distance between the angle of Louis and the midpoint of right atrium varies depending upon the position of the patient. That's why that has been deleted as the method of testing for venous pressure. The current method is you make the patient sit on the edge of the bed with legs hanging down and look at for the venous column within the two heads of sternocleidomastoid.
So anything about that,
if the venous pulsations are seen, venous pressure is elevated. If the venous waves are not seen, venous pressure is normal. So that is only for measurement of venous pressure. For analysis of the waves, you need to put the patient in a way wherein you are able to see upper pulsating venous column. So you are making the patient lying down at 45 degrees is valid for analysis of two things. One is analysis of the waves. Second one is analysis of the venous pressure in response to respiration. For venous pressure per se, that method is invalid now.
So what is your interpretation of the LA pressure with a positive hepatojugular reflex?
Sir, there is positive hepatojugular reflex. There can be a decreased RV compliance or impending RV dysfunction, sir. So that is
what
why
about
there is.
The LA side? Left side?
Sorry, sir.
Does hepatojugular reflex indicate something on the left side also?
I think they have to read the paper by
legal.
Perloff. Original paper by Perloff and Lynn Stevenson. They found that the jugular venous pressure is elevated in patients with where the LA pressure is also elevated. So that was the only study I know of wherein they tried to correlate.
And this has been sort of correlated in the ESCAPE trial also. ESCAPE trial also mentions that the positive hepatojugular reflex is a sign of left heart failure also.
Okay, let's move on.
This is the Lindolfi sign in which we can see the pupillar constriction with the cardiac cycles. And
what is the clinical significance of this?
Sir, the Lindolfi sign, Quincke sign, and all the peripheral signs are due to the wide pulse pressure and the aortic runoff. So that is why.
It's not no. You could go back and read again. Read again, Brownwall. These signs are indicators of high pulse pressure. Yeah. it doesn't quantify the severity of AR. You can have this, for example, even that Hill sign, which is the difference in systolic blood pressure between upper and lower limb. At one time, we used to say quantify the degree of AR based on the Hill
Based
sign.
on the, yes.
But now it is not. It has been proved that it is unreliable. Anyway, these are all more of historical interest. With clinical relevance in quantification of the AR is totally unreliable. If they are present, fine. You suspect there may be aortic runoff. But you cannot use it as a specific sign of AR. Let's move along.
Any hyperdynamic circulation can cause.
Sure. Go ahead.
Cardiovascular system examination inspection. Chest wall is bilaterally symmetrical. Precordium appears to be normal. No bulge or retraction. Trachea is.
I have a small objection to the word cardiovascular system. Whatever you have mentioned earlier, that is also part of CVS. JVP, blood pressure, pulse, they are also part.
Yeah, that's why I keep telling it should be labeled as precardial examination.
Precardial examination.
Oh.
Okay.
There are no dilated veins or scars, no spine deformity. Apical impulse is present in 6th intercostal space, 2 cm lateral to mid-clavicular line. On palpation, inspectory findings were confirmed. Apex peat is in left 6th intercostal space, 2 cm lateral to mid-clavicular line, which is forceful and ill-sustained with medial retraction, that is LV type apex. There is grade 2 late systolic parasternal heave. P2 is palpable. S3 is palpable at apex. There are suprasternal pulsations are present and epigastric aortic pulsations are also present. There is no thrill or rub. Percussion. Left heart border corresponds to apex beat in left 6th intercostal space. Right heart border is retrosternal. Left 2nd intercostal space is dull. And liver dullness present in right 5th intercostal space and trough space is tympanic. Auscultation. S1 is normal. S2, A2 is normal. P2 is loud and there is narrow split. S3 is present and there is no opening snap. S4 ejection click or other added sounds. Coming to the murmurs, there is high pitched, soft blowing, early diastolic murmur in left 3rd intercostal space, starting with A2, decrescendo type, extending more than half of diastole, best heard with diaphragm of the stethoscope in sitting up and leaning forward position. There is high pitched grade 3/6 pansystolic murmur present, which is best heard at apex, starting with S1, radiating to the posterior axillary line, best heard in left lateral decubitus position with breath held in expiration. In other system examinations, respiratory system, there are bilateral basal crypts present, abdomen, gastric tympani present in left hypochondrium, and CNS is normal.
So what is your final conclusion?
Sir, since sir, we are getting on examination, we are getting signs of severe AR, that is cardiomegaly, then wide pulse pressure and long diastolic murmur, and signs of severe MR as well. So we are suspecting severe AR and severe MR with severe PH as well.
Why do you say severe MR? What is the sign of severe MR?
Sir, for severe in clinical context only, sir, we are assuming that it is severe MR.
No, the question is that in the presence of a severe AR, how do you decide the severity of MR? Because the apex down and out can simply be because of AR.
Yes, sir.
No, the answer is simple. In multivalvular heart diseases, it is difficult to quantify the magnitude of wall problem in these walls. Both MR and AR, both are volume overloaded left ventricle. If the question is asked, how do you grade the severity of MR? Usually, let us say patient has got only MR. Forget about AR. So how do you quantify at the bedside?
Sir, if there is only MR, then cardiomegaly, S3, and wide split S2,
Of
sir.
S2.
Wide split?
S2.
Why is the second sound widely split?
Sir, because in severe MR, sir, A2 comes early because LV is decongested in LA as well. So A2 comes early. So that is why there is wide split S2.
I have to qualify that wide and fixed or wide and variable?
Wide variable split.
Okay. What happens to the second heart sound in isolated severe AR?
Isolated severe AR.
Isolated
Sir,
severe AR.
Sir, in isolated severe AR, sir, the S2 is narrow split, sir.
What do you mean by narrow split?
Narrow split means?
Sir, in narrow split means that in inspiration as well as in expiration, we are able to hear just one sound, one component of S2, or there is an impure note to S2.
No. Can you just define it? How do you classify splitting of the second heart sound? Because this is something you are able to hear two components in inspiration or expiration in severe AR.
In inspiration. In normal situation, we are able to hear two components of S2 in inspiration.
In this
And
way, in severe AR.
in severe AR, we are able to hear a single component in both inspiration and expiration.
Then where the question of split?
Sir, we were getting impure quality of S2.
The single second heart sound in both phases respiratory. The question of split does not arise when there are no two components. Split occurs only, split is described only when the two components are heard. Leave that alone. What happens to what is the behavior of the second heart sound in
when there's only AR?
severe AR?
Sir, in AR, severe AR, since sir LV is
chronic severe AR.
Chronic severe
behavior
AR
is different from acute AR.
Yes, sir. In chronic severe AR, since LV is volume overloaded, so it takes more time for LV to eject blood in aorta. So that is why A2 is delayed. So that is why.
So what happens to the
A2P2 gap narrows, sir.
Huh?
A2P2 gap narrows.
No. Clinically, we say normal split, wide split, or paradoxical.
Paradoxical split.
So that's it. So basically, you have got one valvular heart disease which is prolonged, which is decreasing the A2P2 interval. You have got another valvular heart disease which is markedly decreasing only left heart problem. That is, A2 is occurring early. So apart from the second heart sound, in case of MR, what are the other physical signs that will say that this is severe MR?
Sir, presence of presence of PAH in LVS3, sir.
The radiation of murmur also.
Can you get sustained apical impulse in MR? Do you get sustained apical impulse in MR?
It is ill-sustained.
All said and done.
Forceful.
There is a difficulty in quantitation of regurgitant lesions compared to stenotic lesions. In stenotic lesions, we are using the duration of the murmur, whereas in regurgitation, it is not that easy to quantify by and large. But to answer the question, how to quantify severity of MR, in isolated MR, yes, there is a pansystolic murmur that is conducted to the axilla, followed by an S3, followed by a short MDM. If you have got all the three, then probably it is severe. But the question of pH occurring in chronic severe MR is extremely rare, except at the terminal portion, terminal course of the disease. pH is not that common. We are talking about chronic severe MR. We are not talking about acute MRs now. Okay, let's get back to the case. So you think it is AR plus MR. Etiology?
Sir, chronic rheumatic heart disease, sir.
Chronic rheumatic heart disease.
Okay.
Okay.
Why?
So,
Sorry.
what is the implication of S3 in MR?
Sir, in MR, S3 denotes severe MR, severity of MR. So S3 is present in severe MR, sir.
And the implication of S3 in AR?
Sir, in AR, S3 can be present in moderate AR as well.
No.
No.
I'm asking you an implication of audible S3 in isolated chronic severe AR. Important to remember this because that indicates there is LV dysfunction. So in valvular heart disease, presence of S3 in AR is LV dysfunction. Presence of S3 in isolated chronic severe MR, it is severe MR. So basically, these are all, they are all what do you call designed and discussed before the era of echo Doppler era. Because now probably we've got better methods of quantifying that at the bedside. Go ahead.
So similarly, you have a sustained apical impulse. It's in MR, it is LV dysfunction. Otherwise, you don't get a sustained apical. Whereas in AR, you can get a sustained apical impulse without LV dysfunction.
Okay.
Why is your patient NYHA class 4? From your
Sir,
diagnosis, what is the possible reason?
Sir, patient had orthopnea, so that is why he was in NYHA class 4. But this, patient was prescribed some diuretics, so that is why currently she is in NYHA class 3, sir.
No, but why is she so symptomatic? Do you think it's just the MR and the AR, or is it something else that has happened?
Sir, MR and AR combined causes, sir, they can cause increased LV EDP, thereby causing increased LA pressures and then causing PVH and PVH. So that is how it can cause orthopnea and class 4 symptoms, sir. Also, there can be some arrhythmia as well present, atrial fibrillation in a background of chronic MR-AR, which can precipitate, which can increase LA pressures and cause PVH, sir.
Do you think LV dysfunction is set in?
LV dysfunction, if present, then
What are the signs of LV dysfunction?
Sir, in LV dysfunction, sir, the apex will be diffuse, but in our case, it is localized. So LV dysfunction will cause
I don't agree with that. You know, a diffuse apex can be in any LV enlargement, even in the absence of LV dysfunction. Like a severe aortic regurgitation can give rise to a diffuse apex even in the absence of LV dysfunction.
Sir, the peripheral signs of AR will not be present, will reduce in case
important
of...
thing is that
That
the
is one.
diastolic
What
pressures
else?
will rise. It won't be
Yes, sir.
low.
Diastolic pressures will rise.
Then sustained apex may indicate LV dysfunction.
Sustained apex, yes.
Shall we move on to the ECG and
Yes, investigations.
Yes, sir. So Dr. Abhishek will be presenting ECG and investigation.
So I'll be presenting the ECG and X-rays. The 12-lead ECG with normal paper speed and standard calibration. Patient has a normal sinus rhythm with a heart rate of around 80 beats per minute, with a mean frontal QRS axis of around 60 degrees, with signs of LA enlargement as well as volume overload type of LVH.
Is there any evidence of pH? Because the clinician was suggesting there is pH.
Sir,
on the ECG?
Sir, our waves are not showing any signs of pH. Normal.
pH.
Sir, the axis is normal and there are not many signs of pH in the ECG.
How do you know from the precordial RS complex that it is largely due to AR or MR? Both are volume overload state. How will you differentiate between AR and MR from the precordial ECG? That is V1.
Sir, if there are signs of LA enlargement, then
No, we want only the R and S ratios.
Sorry, sir.
See, if there is a deep S wave,
Yes, sir.
in V1 and V2, very deep S waves, V1, V2. It's
Yes, sir.
more likely due to AR rather than to MR.
MR. Okay.
Okay, let's move on to the X-ray.
This is a chest X-ray PA view showing a CT ratio of around 0.6 with the LV type of apex with signs of LA enlargement, and there is dilatation of MPA as well as there is straightening of left heart bottle. There is signs of PH as shown by the dilatation of RDPA, as well as there are signs of PH. We can see curly B lines.
You're telling that PAH is there because right pulmonary artery.
Descending.
There is no descending pulmonary artery. There is only right pulmonary artery horizontal portion. It has to be. Yeah, that descending pulmonary artery has to be larger than the tracheal shadow.
Yes,
Yeah, it is not there. There is no descending artery there. Anyway, that is a different issue. But do you think that there is pulmonary venous hypertension here? What is the criteria used to diagnose pulmonary venous hypertension in chest X-ray?
Sir, if there is cephalization, there is a piece of.
No, that is what I'm trying to ask. Kindly define what is cephalization.
Sir, there is redistribution of pulmonary vessels towards the upper lobe of.
No. How do you recognize? The student wants to know only the upper lobe vessels are bigger or smaller than some other component, or
how do you
Sir,
do
normally due to gravitation, the lower lobe vessels are more prominent than the upper lobe vessels. But when there is PVH, grade 1 PVH, there is equalization of vessels.
No. In this X-ray,
yes, sir.
Do you feel that upper lobe vessels are bigger than the right lower lobe vessel?
It's almost similar.
It is not similar. Certainly, lower lobe vessels are bigger.
Yes, sir.
So basically, I'm not convinced that there is. What are the radiological signs other than Kerley lines about pulmonary venous hypertension? Other than Kerley lines and cephalization?
Sir, there can be peribronchial cuffing and there can be alveolar edema as well as pleural effusion.
Peribronchial cuffing is one. Not pulmonary edema, right? We are talking about it.
Yes, sir.
What are the other signs?
Radiological
signs.
Pleural effusion can be a sign of.
Okay. Agree. Then? Perihilar is?
The bat wing appearance of.
Not bat wing appearance. Perihilar is different from bat wing. Bat wing is bilateral, and then that is a different issue.
Yes, sir.
So, fluid in the minor fissure?
Horizontal fissure.
That is also sign. So there are 6 signs. Anyway, we will not go into that. Okay, so based on this, you think that there is a massive cardiomegaly?
No, sir.
Is there a left atrial enlargement? What is the criteria you have used here?
Sir, there's splaying of carinal angle. It appears.
I'm not convinced about splaying because the angle looks still acute only. It's not obtuse.
More than 70 degrees.
Difficult. Okay, go ahead. Is there a no? You go back to the previous one.
Yes, sir.
Is there enlargement of the left atrial appendage?
Left atrial appendage is dilated.
Also looks like LA appendage. There is this straightening of the left.
No. Why do you say straightening when the pulmonary artery is dilated? It can't
not exactly straightening, sir. There is enlargement of LA appendage, sir.
I'm not convinced. What is the implication of LA enlargement in valvular heart disease?
What is this, sir?
What is the importance of left atrial appendage?
The clot is formed more in that, and then we have to.
No, not that.
So,
the appendage is involved, then it is due to
rheumatic origin.
It has to be rheumatic.
It has to be rheumatic.
One of the signs, one of the radiological signs that LA appendage enlargement is only due to rheumatic process, not due to LA hypertension. Okay, go ahead.
So this is the Black's view of the echo, showing a dilated LA and a dilated LV, with the anterior material leaflet appears to be thickened.
What is the normal thickness of the leaflet?
It's a less than 0.3.
Normal thickness means you should say the upper value, not but not the lower value.
So 0.5.
Sorry, what did you say?
0.5, sir.
0.5. 0.5 what? Kilograms or? What are the units? 0.5 centimeter?
Millimeter.
Or millimeter?
This.
No. Kindly just go back to the
keep the plaques.
Yeah. Plaques view. Yes. You think the mitral valve is showing solid?
Sorry, sir.
Does the mitral valve show rheumatic etiology?
Is there a rheumatic involvement of the mitral valve? How do you know?
AML is thickened and it appears to be little doming, but the
hallmark of rheumatic mitral valve involvement. Echocardiographic hallmark.
So AML thickened doming and PML restricted.
AML dome, PML restricted.
Yes, sir.
So how do you assess PML restriction?
Sir, we assess that on M mode, and we see if the PML is moving with the contraction or not.
Moving with contraction means moving posteriorly.
Yes, moving posteriorly.
That is not correct. That's not correct.
No, don't move posteriorly. It will move.
It will move,
along with
but it
AML.
will move in the wrong direction. It will move anteriorly.
Anteriorly.
Why?
Because of?
Sir, attachment of the.
No. That is outrageous in the sense that the sign of a rheumatic valve is commissural fusion. Commissural fusion is the one that carries the anterior leaflet is bigger and moves anteriorly. So it carries with it the posterior leaflet anteriorly. So it is this paradoxical motion of the PML that characterizes the rheumatic etiology. Does it involve only the leaflets or anything else?
Sir, it involves the myocardium also.
Myocardium?
Subvalvular.
No. Wait. Where did you get that value of myocardium? Actually, people have gone out of the way to say that there is no rheumatic myocarditis.
Involvement is not there at all. Yes, in rheumatic.
So what are the other structures that are involved in the rheumatic process other than the leaflets? What is subvalvular apparatus?
Subvalvular apparatus.
Subvalvular apparatus, how do you assess it?
Hello, sir. Sir,
See, whenever you describe this pathology of rheumatic, remember the 4 C's: commissural fusion, caudal fusion, aspal thickening, and combine.
Yes, sir.
Okay, go ahead. The LV normal or abnormal? LV size?
Sir, LV is dilated.
What is the upper limit of normal LV size? End-diastolic dimension.
50. Females.
No. LV end-diastolic dimension. In an adult. With a body surface area of 1.73 meters square.
According to BSA, sir.
You're aware of it or not aware of it?
Yes, sir. 70 ml per meter square.
You're talking about volumes now.
Volumes.
Talking
Yes,
about
sir.
dimensions. 70 ml is milliliters or cc, cubic centimeters.
Yes, sir.
So that is volume.
Sir,
Talking about dimensions.
sir, it is around 30 per meter square.
Okay, move along. Move along. Okay, that's not acceptable. Go ahead.
This is the short axis view showing the normal LV contractility, and
Wait. What do you mean by contractility?
Uh,
You have to be very careful about usage of the words. Science is precision.
yes, sir.
Then
Uh, normal LV sir systolic function.
LV systolic function. Okay,
Right.
go ahead.
So this is the apical four-chamber view showing a dilated LA and a dilated LV with posteriorly directed eccentric severe MR. And so this is the continuous wave Doppler across mitral wall showing a dense triangular MR envelope with early peaking signal. Yeah.
So what are your criteria to say that the MR is severe?
Sir, criteria.
Doppler criteria.
Sir, criteria for severe MR is VC for vena contracta that should be around equal or more than 7 mm, and effective regurgitant orifice area should be more than or equal to 0.40, and regurgitant volume should be around more than or equal to 60 ml, and LV ejection fraction should be more than or equal to 50%.
LV ejection fraction.
Yeah. Why
Regurgitant
bringing
fraction.
that?
Are
Okay,
these,
that's
these are all load dependent or load independent parameters?
Load dependent.
So tell me the load independent parameters of severity of the regurgitation. Because it's a multivalvular heart disease.
Yes, sir.
So in multivalvular heart disease, isolated parameters are not applicable. So you need to separate out the load independent parameters from the load dependent parameters. So tell me the load independent parameters of severe MR.
Sir, if EROA, sir, vena contracta, sir, width, and
that's all. There's nothing more. Rest of the things are all load dependent. Okay.
Yes, sir.
I think we'll move on because it's getting time. Late. Okay, go ahead. Further investigations done.
Sir, this is the apical 5-chamber view showing severe AR, and this is the continuous wave Doppler at aortic vault across. It is showing a dense diastolic envelope with a short pressure half time with steep deceleration slope.
Okay.
This is a suprasternal view showing whole diastolic reversal, and which was then confirmed in the M mode. So the final diagnosis we made was a chronic rheumatic heart disease with severe valvular aortic regurgitation, with severe valvular mitral regurgitation, with severe PVH and PAH, and normal sinus rhythm with normal LV function, currently in NYHA class 3, with no history suggestive of infective endocarditis or acute rheumatic fever.
What are the non-rheumatic heart disease causes of multi-valve heart disease?
AR and MR.
Non-rheumatic.
Sir, in connective tissue disorders can be there, such as Marfan's and Sir Endler-Danlos and Lois-Dietz.
They're all connected to disorders. So,
Yes,
so that group is over. Any other?
It can be a calcific, if age is not the criteria, then it can be a calcific valve disease, which can involve aortic as well as mitral annular calcification can be there. And
this is severe MR, severe AR.
Sir, that is not likely to occur in calcific.
That's all. You have got only 2 causes.
Sir,
There are 10 causes.
carcinoid syndrome, sir. Sir,
Carcinoid syndrome involves the right side or left side?
right side, sir. Right side. TR and
When
KR.
does it involve the left side? Not sure.
Not
Go
sure.
ahead.
Okay.
Then there can be autoimmune diseases such as SLE or
You already told that.
Yeah, but can be rheumatoid, SLE, all that corrective
then
tissue. Okay.
there can be
What about infective endocarditis?
infective endocarditis can also cause multiple.
What about drugs causing valvular diseases?
Sir, ergot derivatives and sir, fenfluramine can cause, sir.
So there are almost 10 causes. You can read it in,
Yes, sir.
there are 2 or 3 articles on the etiology of multivalvular heart disease.
Yes, sir.
Okay. Then post-intervention is another thing. Okay. Let's move along. So how do you want to approach the treatment?
Regarding the severity of this presence of severe AR and MR, and considering the age of the patient, as she is young aged, so we'll prefer double valve replacement and preferring this mechanical prosthetic valve. Yes.
What kind of valve would she wants to get married? She's unmarried.
If she is planning for pregnancy, then we'll prefer a bioprosthetic valve.
Name the bioprosthetic valves that are available in our country.
Parcival valve.
Sorry?
Parcival bioprosthetic valves.
No, you have to name at least 3 bioprosthetic valves that are available in India.
Edward.
Read up. Okay.
Yes, sir.
Arun, it's all yours.
How much will you keep the INR?
INR will keep target will be 2.5 to 3.5. If mechanical prosthetic valve is there, in case of double valve replacement.
What is
See, when you're mentioning INR, many people don't like a range. You must say only one value.
3.
3, correct.
No, but I think you need to find out what decides the intensity of anticoagulation in a valvular heart disease after prosthetic. What decides? Is it your location of the intensity of anticoagulation? That is INR. Is it the location of the valve? Is it the number of valves? Is it the type of the valve? Is it the is it duration? There are about half a dozen factors that influence your intensity of anticoagulation.
Correct.
So you need to keep that in mind.
Yes, sir.
Yes.
What is INR? Everybody talks about INR. Why not we do only PT? Why are we doing INRs? What is INR? What is the full form?
Normalized ratio.
No. Okay, what is INR stand for?
International normalized ratio.
Sorry?
International normalized ratio.
Yes, sure. So what is the big advantage of INR or conventional prothrombin ratio? Why are we doing INRs? Or why are we insisting on INRs? Anybody?
Student panel?
No.
It is lab standardized actually.
Sorry?
Standardized according to the lab. So the patient's INR to the ratio of patient's INR to the patient's prothrombin time to the standardized value of the particular.
No, how do you standardize, sir? That is what exactly I'm trying to ask. How do they standardize? What is the standard there?
What is the standard there?
What is being standardized? Which component? I think you need to go and read. This is fundamental. You cannot be excused on that. Okay. Arun, I think it's getting late.
Sir.
Yeah, please go ahead
Thank you, sir.
complete the asking.
Thank you.
Yep.
Thank you. So it was a fabulous discussion. We all learned a lot, and it was an exceptional discussion. Thank you both the uh, presenter and the student panel team and the examiner. Uh, so Dr. Harshit will now take over. I think the presenter may please stop sharing so that Dr. Harshit can take over.
Thank you,
Yeah,
sir.
so now fasten your seatbelts and be ready for the OSCE. Again, reminding that this is not only for those the case presenter and the student panel. Everyone who is attending is welcome and invited to please attend the OSCE live. And yeah, the floor is yours, Dr. Harshit.
Thank you, Dr. Arun. Uh, Before I begin, I would like to thank and congratulate our organizer and the stalwart panelists who had a great discussion. And I hope it was a great learning session for all. And with this quiz, OSCE type quiz, we hope everyone learns something from this. And Vinay, can you put up the slideshow? So I will read the rules for the OSCE. Here you will be able to log in the browser based this app menti.com, and using the QR code you can log in, and then you will have questions displayed on your screen, and then you can answer on it. So the questions will be displayed for like 60 seconds timer for each question, and you have to ensure you answer before the time runs out. There are no negative marking, and the one who answers the fastest will collect more points. And you should have a good connectivity issue with the internet, and aggregate score of the fastest answer. The person who answers the fastest will be recorded by the system to determine the final winner. So please enter your full name and as you register in this, and there will be a prize after the course. So we will wait while everyone joins.
Vinay, you can show the no. The joining.
Join. How many people have?
Yeah.
35 have
All of you,
joined.
please. Yeah. So you have two options. You can either use your mobile phone and scan the QR code and then join, or you can do it from a computer, a tablet, or a laptop, whatever. And then you can answer on your mobile phone as well. You just need to ensure that you have the Zoom link also open and the web browser also open. So those who are answering on the same system that is on the mobile will need to swap between the two. That's all. If you're not able to see scan the QR code, you can just go type www.menti.com, and then it will ask for the code of the quiz, and then just type that 8-digit number, and you will get into the waiting room. You will not be able to see the questions now, because only when we move to the next slide will you be able to see the questions. And it is a multiple choice based OSCE. So the options will come at the right time, and then you just need to click on the mobile or the system where you are using, and then you will be able to answer.
Hello? Chapandi?
So those who have used if you are scanning the QR code, you wouldn't need to enter the code. The number may not be required. You can see the number on the screen. So you all people will be able to join in between also. So don't worry. So if anybody has not been able to, if anybody has got a problem, you may please use the raise hand button on the Zoom, and then, or you can put in a message. I think most of the people have been able to do. Yeah. So I think we are good to go. Are we? Probably yes.
We have
Vinay, can
about
we
58.
start?
Yes, sir.
Yeah.
Whenever you say.
Yeah. Okay. Dr. Harshit can guide. Yeah.
Yeah, I'm ready.
We can move forward probably.
So we start off with the first question, which says, what is the most likely diagnosis of the patient with the M mode displayed here? You see a M mode here, and it is showing the vertical line, dotted line is showing where the M mode is. And then you will have to answer the question. What is the most likely diagnosis? The options are Arun, can you display the options? Oh, sorry, Vinay. So the first option is severe aortic stenosis. Second option is bicuspid aortic valve. Third one is severe LV systolic dysfunction. And the fourth is severe mitral stenosis. So most of you have already answered, only 8 seconds left. So most of you answered correctly. This is a bicuspid aortic valve. If you can go to the next slide, Vinay. So you can see here in the M mode, we see the eccentric closure line of the aortic valve, which is showing quite eccentricity. And so this is a feature of bicuspid aortic valve. It is not severe AS because you see just ahead of this eccentric line of closure, we see the aortic valve is opening well. So this cannot be severe AS. Also, with this good aortic valve opening, it cannot be. It should be having a good stroke volume, and so LV function cannot be severely impaired. So it cannot be severe LV dysfunction. And in the M mode itself, if you see where the M mode was cut, you see there was some hint of LV. Dimensions were not those of underfilled LV. But again, we cannot see the mitral wall in this M mode only. So it would be an exaggeration to say there is some underlying mitral stenosis. We can just say the most likely correct option is bicuspid aortic valve. So we move ahead to the second question. Vinay, can you please show the second question? So second question, a long one, but easy. Here you see a 48-year-old male with a history of IV drug abuse, with history of fever and chills for 1 week, and sudden onset breathlessness. Examination reveals a heart rate of 102 and a murmur. His echocardiogram, continuous wave Doppler spectral is shown in the figure, and it is showing the CW at the mitral annulus towards the LV. The peak velocity recorded is 5 meter per second. So what is the most likely etiology of his symptoms? Can we have the options? Be ready to answer as options appear here. So the first option is complete heart block. The second option is acute severe aortic regurgitation. The third option is severe systolic heart failure. And fourth option is acute severe mitral regurgitation. The fifth one is acute severe tricuspid regurgitation. Take your time and then answer. There is ECG attached to this image. You can take help for it. So most of you have answered this as acute severe mitral regurgitation. And I should clarify because this is an incorrect answer. The acute mitral regurgitation, firstly, would not be causing this diastolic MR. Acute mitral regurgitation, severe mitral regurgitation doesn't cause severe, doesn't cause diastolic MR, firstly. Second thing is the spectral Doppler shown here, it is not complete. It is incomplete and not triangular. So it doesn't in fact suggest severe MR itself. So that option is out. The other option that was acute severe AR, we see diastolic MR in acute severe regurgitation. And also there was an option of complete heart block. In that also AV blocks, we can get diastolic MR. But the thing is here the patient had a heart rate of 102 already. So that option goes out. So the correct option was acute severe aortic regurgitation. Also, acute tricuspid regurgitation, severe tricuspid regurgitation would be causing diastolic rumble on the right side or the left side as well. So that is also out. I hope this one gets clear with everyone. So can we go to the next option? Next question, please. Which of the following aortic valve finding is not consistent with the M mode displayed in the figure? The M mode is shown here at the aortic valve, at the mitral valve, and it is asking for the aortic valve findings. Vinay, please show the options. So the first option is mild aortic regurgitation. Second is moderate aortic regurgitation. Third is early closure from severe aortic regurgitation. Fourth is aortic valve vegetation. And fifth one is aortic fibroelastoma. This is an easy question if you are able to like make odd one out, then you will be easily able to answer this. We have asked which is not consistent with this M mode display. So the correct answer is early closure from severe aortic regurgitation because any amount of air can cause what is shown here in the M mode. First, you see in the M mode, can you go to the next slide if there is an answer to this? Okay, here with an arrow we have shown this is showing the fluttering of the anterior mitral leaflet, and this can be caused by any amount of air. So even mild AR, moderate AR, and even severe AR can cause this, and AR due to any cause like aortic vegetation or aortic wall fibroelastoma, those things can also cause AR and hence AML fluttering. But the thing is, when the AR is severe, that would cause early closure of the mitral leaflet. So that would be guided if we see the ECG here. ECG, the QRS complex, the mitral closure is occurring after the QRS complex. So that means the mitral valve closure is occurring late in the diastole. So this AR cannot be severe AR fluttering here. So only we had to find the odd one out, which was severe AR, while any kind of AR can cause this AML fluttering. I hope this gets cleared with everyone.
I
So
would just like please do not answer in the chat box. That is not the way to answer. You will have to answer on the system. You can use your mobile phone or on this.
okay, some of them are answering on the chat box, yes. So make sure you are on the browser where you have to answer. So can we move to the next question, please? All of the following are causes of loud S1 except a simple clinical question. First option is short PR interval less than 160 millisecond. Second is tachycardia. Third is mitral stenosis. And fourth is premature closure of mitral valve. So most of you answered correctly. This is the correct answer is premature closure of mitral valve because it causes soft S1 and not a loud S1. And all other causes are for loud S1. If you go to the next slide, I have provided some causes of soft S1 here, like prolonged PR, depressed LV function, and premature closure of mitral valve, and even bundle branch block. Can we move to the next question, please? So this question is of historic importance now. You have to identify this personality, and for your hint, I have provided this clinical background. In 1958, a newly appointed cardiologist at the Bethesda, Maryland, sent a young man for open heart surgery for a congenital obstruction in the aortic valve, only to discover no obstruction in the operating room. Later, he had two similar incidents and he acknowledged his mistake and published it as a case series in Circulation, giving the concept of functional aortic stenosis. Who is this personality? Can we have the options? First option is Alan Krieger. Second option is Andrew G. Morrow. Third option is Eugene Braunwald. Fourth option is A.K. Senning. So this is an image of his when he was young and in 1958. This is of that time. So most of you answered correctly. The correct answer is Eugene Braunwald. And actually, he had identified this thing, functional aortic stenosis, and published it with uh, Andrew G. Morrow. And the Andrew G. Morrow option here, he gave the Morrow operation for HOCM. And Alan Kreiber, he was credited with first balloon aortic valvuloplasty and TAVI. And A.K. Senning gave the atrial switch and performed first permanent pacemaker implantation in humans. So can we move to the next question? So this is a question of histopathology. A 25-year-old man died suddenly while jogging, and a post-mortem examination was performed where histologic section of the left ventricle myocardium is shown here. Which of the following statements is true regarding the disease etiology in this case? Can we have the options? Which of the following statement is true regarding the disease etiology? I hope the options are visible on your screen. They are visible on the mobile screen, in fact. The first option is histologic finding are of normal myocardium subjected to chronic vigorous exercise. Second is this is a autosomal dominant trait. Third is it's a disease of plasma membrane protein synthesis. Fourth is the greatest risk to the affected one is of complete heart block. And the fourth one is only one specific mutation has been identified to predict sudden cardiac death in the majority of these patients. So you identify the disease etiology and then you answer these statements. You have to tell the correct one. So most of you have already answered this correctly. This was a case of HOCM. It is a autosomal lead in the dominant trait, and no, this is not was not a normal myocardium. And most of the there have been many genes identified with the HOCM, almost 900 mutations, and 50% of them are linked to beta MHC. And again, the risk is of sudden cardiac death, and the risk is greatest with particular clinical subsets of patients who have like family history or history of syncope or hypotension on exercise testing or multiple NSVT runs or LV thickness of more than 30. So if you go to the next slide, Vinay, we can have some details. Here I have already provided you the details. Like SCM is an autosomal dominant trait, and the risk is of sudden cardiac death. So this is a pretty classical of HCM. Can we move to the next question, please? So for each of the chest radiographs shown in the figure, you have to select the correct combination from the options. So you have a figure where you have been labeled with X-ray panel A. In panel B, again there is X-ray, and similarly in panel C and panel D. You have to tell the correct combination for each of these scenarios. Like Vinay, can you show the options? You have to select the correct combination. For panel A, what is the etiology? For panel B, what is the etiology? And panel C and panel D. So in the first option, I have provided for panel A, ASD as the diagnosis, panel B, pericardial effusion, panel C as aortic regurgitation, and panel D as mitral stenosis. And similarly, there are other options with their permutation combinations. So you answer wisely. If you are able to identify one or two panel figures correctly, then you will be able to match the other two ones easily. So most of you answered correctly. Actually, the first X-ray image, it is showing the RV apex and the biatrial shadow and the L appendage enlargement and PH and PBS signs. But there is, as compared to the fourth one, where we have increased RV apex again, but increased flow situation and a large RA as well. So that is ASD. The panel B, again, there is only cardiomegaly, so it is pericardial effusion. In panel C, you have cardiomegaly with LB apex and dilated aortic root, which is typical of aortic regurgitation. So we move to the next question. So this is an imaging based question. You have a 82-year-old male with history of NSTMI, and on angiogram you have triple vessel disease with 100% occlusion of the LAD and 100% occlusion of the RCA, and there is 70% stenosis in the circumflex as well. The patient undergone viability, and you have to choose the correct option regarding the same. You see the image here. There are rest images and FDG uptake images, and then answer the according options. Can we have the options? So option 1 is there is matched perfusion defect and patient will not benefit. Option B is there is matched perfusion defect but patient may benefit. Option C is there is mismatch and patient may benefit. And fourth is there is mismatch between the perfusion and metabolism but patient will not benefit. So most of you have answered this correctly. And this was, I think, an easy one. There was a mismatch between the perfusion in the rest image and the metabolic uptake in the FDG uptake images, and the patient will have benefit from revascularization. So can we move to the next question, please? So this is a question regarding the LV thickness. You are examining patient and you get these options. It is common for increased LV wall thickness due to athlete's heart to have an increased wall thickness of more than 13 mm. In patients with increased LV wall thickness due to cardiac amyloidosis, the basal wall function is better preserved than apical function as assessed by speckle tracking. In patient with increased LV wall thickness due to cardiac amyloidosis, basal longitudinal LV stent predicts mortality. The fourth one is it is common for increased LV thickness due to athlete's heart to have severe LA enlargement. So you have to choose options for athlete's heart versus cardiac amyloidosis. Which one is the correct one? Most of you answered correctly. Because if we go to the first option, in athlete's heart, there is rarely LV thickness of more than 13 mm. The second option, where it says in cardiac amyloidosis, basal wall function is better, this is wrong. The basal wall function is less preserved compared to apical function, so it gives a cherry top appearance on the strain imaging. And increased LV thickness due to cardiac amyloidosis, this basal dysfunction, it predicts mortality. It has been shown in some studies as well. The fourth option here, it says LV thickness due to athlete's heart. It causes severe LA enlargement as well. This is wrong. It doesn't cause LA enlargement. So can we go to the next question? So this question is based on a patient who is receiving chemotherapy. A 47-year-old female with a history of breast cancer treated with chemotherapy 1 year ago. Now she has symptoms of dyspnea on exertion, fatigue, and lower limb extremity edema. Physical examination reveals a heart rate of 98 and blood pressure of 102/70. Cardiac examination is significant for displaced apex with a soft S3, and lungs reveal basilar crackles. Her records from outside are limited, but patient has received doxorubicin and trastuzumab. Her echocardiogram is shown here. Which of the following does not increase the risk of patients' chemotherapy-induced cardiomyopathy? So you have to tell which of the following doesn't cause increased risk for cardiomyopathy due to cardiac toxicity. Can we have the options, please? Option first is use of doxorubicin plus trastuzumab. Option B is cumulative dose of trastuzumab. Option C is prior history of non-Hodgkin's lymphoma treated with chest radiation. And option 4 is total cumulative dose of anthracycline. You have to tell the chemotherapy doesn't induce cardiomyopathy with which of the following options. The risk is not increased. So the correct answer is total cumulative dose of trastuzumab, because when receiving chemotherapy, doxorubicin is known to cause toxicity, and toxicity with trastuzumab is reversible. And in combination with doxorubicin and anthracyclines, it increases the toxicity risk for cardiomyopathy. Secondly, the cumulative dose of trastuzumab doesn't affect the involvement of like it doesn't affect the risk for cardiomyopathy. And the third one, prior history of irradiation, it also increases the risk for cardiomyopathy. And the cumulative dose of anthracyclines again is linked with cardiomyopathy risk. So the correct option here was B. Can we move to the next question? So we are halfway through, and this is the current standing of the students, participants. Like the first here is Sarath Nagesh. He is answering fastest. So we move on to the next question. Given below is a CAD tracing data from a patient. You have to interpret it and answer accordingly. Given are the oxygen saturation oximetry data as well as the pressure data. Can we have the options? Also, you can zoom on the image if you are unable to see. You can always zoom in on the image. The first option is idiopathic pulmonary arterial hypertension. Second option is atrial septal defect with pulmonary arterial hypertension. Third option is acquired PH, and the fourth option is cor pulmonale. So I see some of you have answered correctly. It's a acquired pH situation. So just for all understanding for all, I would just interpret this oximetry and pressure analysis data. It's showing a normal arterial and venous saturation with no step up or step down, and there is elevated RV pressure and severe pH. Also, there is increased LA pressures, and there is a diastolic gradient between the LA and the LV diastolic pressures. So now we go to the options. The idiopathic pH will have raised PA pressures, but again there will be no gradient between the LA and LV. The ASD will have equalization of RA and LA pressures, and again no gradient with LA and LV. The acquired pH situation is likely here because most common cause is again secondary to MS, mitral stenosis. And the fourth option here is cor pulmonale. That is, this pH is due to secondary to lung etiology. But again, then you will not be having any gradient between the LA and L. So this was a simple question. Can we move to the next question, please? A clinical question. What is the pattern of S2 split shown here, marked with the question mark, as compared to the normal S2 split, which is shown in the figure above? So in this figure, we have marked E2 with a black line and P2 with a dotted black line and shown a normal variation of a split. In the second figure below, you have to answer what is the phenomena happening or what type of split this is. I think sir will be delighted to see this question, although it's a easy one. So the options are wide and flex split, wide and variable split, paradoxical split, and fourth is narrow split. And please don't answer this question wrong. So most of you have answered. In fact, 99% have answered correctly. It's a paradoxical split. And in the image, we can see in inspiration, there are single sound, single component, and on the expiration, we see two components of the S2. In wide and fixed split, there will be no variation between the two components, but we will able to hear two components in the inspiration and expiration. In wide and variable, we will have normal variation with respiration. With inspiration, you will have widening of gap, and with a lesser gap in the expiration. In narrow split, we will have impure note to the S2 sound in the inspiration, and in expiration, a single sound. So that's it. Can we move to the next question? So this is a basic question from electrophysiology study. Which of the following is true about the phenomena shown here? You have the EGMs from the RA and the His and the coronary sinus channels. And we have marked for your help the A wave and the H wave. And you have to answer the options that follow. You have to tell which one of them is true. Can we have the options? A dual AV nodal physiology is diagnosed by an increase of at least 50 milliseconds in AH interval. 25% of patients without SVT also demonstrate dual AV nodal physiology. Dual AV nodal physiology had good sensitivity and specificity for diagnosing AV and RT, or all of the above are true. So the correct answer is all of the above are true, because dual AV nodal physiology is diagnosed with AH jump, and you say AH jump whenever there is increase of 50 milliseconds in the AH interval with A pacing. And in fact, it can be seen even in patients without SVT. So it can be a normal thing as well. And it has a good sensitivity and specificity for AV and RT, almost up to the tune of 89 to 90%. So all of them were true. Can we go to the next question? So this is a CT based question. You have a CT image, an oblique view, where you are able to see the four chambers, and you have to select the case scenario which is most appropriate for the disease etiology here. There is a disease etiology shown in this figure, and you have to answer what is true regarding the scenarios, case scenario presentations. So first option is 53-year-old female with significant weight loss, recurrent syncopes and dyspnea. Second option is 21-year-old male with recurrent syncopes. Third option is 69-year-old woman with recent MI and subsequent stroke. Fourth option is 71-year-old man with JVP raised and ascites and marked peripheral edema. So you have to identify the disease shown here and then answer its clinical presentation. So we had very wide group of answers here. Many of them have answered option A. Some of them have also answered C. So I think if you are able to identify the etiology here, then the answer would be easily picked up. The etiology here is, you see, there is a homogeneous mass attached to the interatrial septum here. And this is a case of cardiac myxoma. And this patient would be having constitutional symptoms and recurrent syncopal attacks and associated dyspnea. The option B would have been correct if this was a case of like ARVD or something. Or the option C would have been correct if there was a large LV thrombus, which would have caused subsequent stroke in a MI patient. And again, there are no features to suggest RV cardiomyopathies, which would have been correct in the fourth option. So the first option is the correct one. This is a case of cardiac myxoma. Can we go to the next question? So this is a echo-based synchronization therapy, and the question is, a 63-year-old male undergoes cardiac resynchronization therapy and returns for echo after 3 months with atrioventricular optimization because of continued dyspnea. Initially, his AV delay was set at 120, which was out of the box implantation, and his baseline mitral inflow is shown in the figure A. The panel A here shows the baseline AV delay and the associated mitral inflow pattern. And in panel B, when his AV delay was changed to 160 and then to subsequently 200 millisecond, this was the mitral inflow pattern. And you have to answer the likely explanation for this. Can we have the options? The first option is intra-atrial conduction delay. Second option is a dislodged right atrial lead. Third option is loss of biventricular pacing. And the fourth option is persistent atrial fibrillation. The key here is to identify the mitral inflow waves. Then you will be able to answer this. So most of you answered correctly. It's a intra-atrial conduction delay phenomena which is happening here. At the baseline, when out of the box implantation, the AV delay was set at 120 milliseconds. And if you see in the ECG in the diastolic period, there is no A wave, only E wave is there in the mitral inflow pattern. And subsequently, when it was changed to 160, the atrial kick added to the ventricular filling, and we can see appearance of E followed by a small, very small A wave. And in the subsequent slide panel image, you see AV delay when set at 200. We see this A wave enlarged. So this was probably due to intra-atrial conduction delay only, and so atrial kick was not added to the ventricular filling, and so there was limitation. The second option here, dislodged right atrial lead, is not correct because if there was loss of A wave due to dislodged atrial lead in the panel A, we see no A wave, but it would have not been corrected with the change of AV delay if there was a dislodged atrial lead. Again, with the loss of biventricular pacing, as in option C, it would not be corrected with change of AV delay. And the fourth one, persistent AF, is again wrong because there is an appearance of A wave in the mitral inflow. in the panel B. So this is not a case of AF, persistent AF per se. So can we move to the next question, please? This is a question from MRI and clinical history answers it easily. Patient with history of congestive heart failure and bradyarrhythmias. You have to tell the likely diagnosis. And this is an MRI image. Can we have the options? The first option is cardiac amyloidosis. Second option is cardiac sarcoidosis. Third option is idiopathic dilated cardiomyopathy. And the fourth option is hypertrophic dilated cardiomyopathy. So majority answered correctly. It's a cardiac sarcoidosis. You see in the MRI image, there is subepicardial enhancement typical of sarcoidosis. You don't see such enhancement in amyloidosis. You have subendocardial enhancement. And in DCM, you have patchy or linear mid-wall enhancements. And in HCM, you have mid-wall enhancements. So subepicardial is typical of cardiac sarcoidosis. Please move to the next question, please. So this is a CAT tracing question. You have been shown LV and aortic tracing from a patient undergoing a percutaneous procedure. What is the apparent hemodynamic derangement in this case? What are the options? Actually, you don't need the options. The first is dynamic LVOT obstruction. Second is fixed LVOT obstruction. Third is severe mitral regurgitation. And fourth is severe aortic regurgitation. You have to answer in the Menti app. You don't have to answer in the chat box. So most of you answered correctly. It's a severe aortic regurgitation. You see there is a early diastolic gradient between the LV and the aortic tracing. And this was probably due to balloon dilatation at the aortic wall with a wide pulse pressure and in lower diastolic pressures of the aorta. There was no LVOT obstruction here because there was no gradient between the systolic pressures of the LV and the aorta. Can we move to the next question? So this is a question about how to make the diagnosis of severe aortic regurgitation. the parameters which will meet the criteria for severe AR. A jet with and LVOT diameter ratio of more than 70%, vena contracta width of 0.5, aortic regurgitation PHT of 260, regurgitation fraction of 40%, and all of the above. So there, this was answered quite quickly, and the first option is the correct option because for severe AR you have to have the jet with LVOT diameter ratio of more than 65, vena contracta of more than uh, 0.6, and the aortic PHT of less than 200, and regurgitant fraction of 60%, and regurgitant volume of 50. So that's it. Can we move to the next question? So again, this is a simple question from cat tracing. Pull back from ascending aorta, and you have to tell the likely diagnosis. Can we have the options? Options are supravalvular aortic stenosis, valvular aortic stenosis, or a subvalvular aortic stenosis, or none of the above. So the correct answer was supravalvular aortic stenosis, where you will have gradient between the aortic tracing itself. In valvular aortic stenosis, you will have gradient between the LV and the aortic tracing. And in the subvalvular aortic stenosis, you will have gradient between the LV tracing. So can we go to the next question? So this is a question which I made from the echo spectral. So we were having a patient examined, and from his hemodynamics, this question was made. This is a spectral Doppler tracing from a patient, one at the aortic wall and other at the mitral wall. And you have to tell his approximate systolic blood pressure. In the first CW, you have the velocity of 4.6 and gradient of 87. And in the second, you have gradient of 183. You have to tell his approx systolic blood pressure. So many of you answered correctly. It's 106 millimeter of mercury. This is because if you go to the next slide, I have provided some explanation. CW at the mitral wall gives you the LV systolic pressure minus the LA pressure. So, which would be of around 183, and which was already given. And aortic CW will give you the LV systolic pressure minus the aortic pressures, which are 87, gradient already given. So taking LA pressure to be 10, the systolic blood pressure would be adding LV systolic pressure plus 10 of LA, and then subtracting this gradient, that would be 106. So I think this concludes our OSCE presentation. Can we have the name of the winner? So, the winner is Sarath Nagesh. Congratulations, Sarath. I hope all the
Congratulations, Sharath.
participants did enjoy this and
Yeah,
had
I
something
think
to learn
Sharath,
from.
yeah, it was a great quiz, Dr. Harshit. And can we identify the person who came second? Because Sharath won last time round also. I think Harsha, isn't it? Harsha is the person who came next. Sharath was the winner of last month's quiz as well. So I think we will award the prize to the next. Yeah, Harsha. So we request you to please send your full name and your contact information so that we will send you your prize. It includes an Amazon gift voucher and your complimentary registration for the HFAI 2027 at Thiruvananthapuram. So wonderful session we had. Thank you, Harshit. It was a very good session. And we had a great session overall today, starting off from an excellent talk by Dr. Veena Nanchappa, and the discussion ensued was excellent. And the examiners guided us through the case discussion. Dr. Balendra sir, Dr. Dayasagar Rao sir, Dr. Ajay Behal sir, Dr. Harshit. And thank you, the case presenters from SCPJ, Dr. Pibas and team, and the student panel from PJ Chandigarh, Dr. Chinmay, Dr. Meheri, and Dr. Karthik. And although Dr. Aditya Kapoor sir could not join today, thank you. Thanks to sir for his continued presence and for sending Harshit through as well. And we had an excellent OSCE as well from Dr. Harshit. I should thank the entire team from Heart Association India for having this clinics go time and again on a monthly regular basis. And this year we've had a very good OSCE as well, OSCE series as well, and keeping us all on our toes and keeping us learning new facets from experts all over the country. Thanks to Chopra sir, Abraham sir, Venu sir, Harishan sir, Dr. Sajan, and everyone who worked in the background, the HFAI team, Sumita, the team from Hallmark, the audiovisual team, and our sponsor Sun Pharma, and all our associate partners from across the globe, the Heart Failure Society of America, and others. So we had a wonderful session. Vinay, I hope you will be able to connect with Dr. Harsha.
There were two Harshas in the chat, in the audience.
Yeah, can
Harsha
will you be
Kumar,
able to identify it, Harsha?
I think he's given his name in the chat box with his phone number and email address.
Yeah, very good. Yes, Harsha has come. Harsha has, we've identified. Vinay, you will be able to capture that, no?
Yes.
Yeah, so that is good. Good. So we'll send it through. So congratulations. Congrats, Dr. Sharath as well for continuing very good answering. And thanks everyone for staying back and joining us throughout. We had a wonderful session. Thank you all, and we'll join next month for the next episode of the Heart Failure Masterclass from HFAI. Thank you, sir. Good night.
Thank you. Thank you.